Hello, everyone. Thank you for joining us today. We have a wonderful presentation in store for you. We are going to be talking about utilizing intravascular lithotripsy for large bore access, specifically in TAVR procedures. My name is Jay Mohan. I'm an interventional cardiologist in Southeast Michigan outside of Detroit, and I'm happy to have Dr. Kalik from New York City join me today for this session. These are our disclosures. This program is provided by HMP Education, an HMP Global company, supported by an educational grant from Shockwave Medical. Our objectives today are to identify the best practices for large bore access in TAVR procedures, understanding the data that surrounds lithotripsy for large bore access, and safely obtaining large bore access during endovascular aortic repair. To start, I'm going to start by presenting intravascular lithotripsy, specifically in regards to vessel compliance in large bore intervention. So in this procedure, I want to talk about many different strategies for large bore access and how intravascular lithotripsy has really changed our strategies for managing large bore access. We'll talk about specifically how IVL or intravascular lithotripsy works to change vessel compliance and how that has helped us with large bore access. So, as everyone knows in interventional cardiology and specifically in structural heart disease, calcium has become our biggest adversary. Vascular calcium is an issue in multiple vascular territories, specifically in vascular interventions and in endovascular interventions and structural heart interventions. It leads to the inability to deliver our equipment. Specifically in structural heart, we use large bore sheaths, and oftentimes going through a calcified artery makes intervention very difficult. And as everyone knows, specifically, we've seen in the coronary system, the same thing exists in the peripheral system, that when there's a lot of calcium, we run into a lot of complications. And, we can do an amazing structural heart procedure, but then at the end of the procedure, when we're dealing with our access site, if there's a lot of calcium, we tend to run into these vascular complications. And then also, if we don't adequately treat the calcium, we run into a lot of suboptimal results. And we're learning more and more that modifying plaque and calcium leads to better outcomes. Lithotripsy has been a new development in both the coronary, endovascular, and structural heart field. And what's been really amazing about it is that it can safely and effectively treat calcium, leading to much more improved outcomes, and more importantly, our ability to do these procedures safely. So why does it matter? Why does changing compliance matter? I mentioned that earlier, and I like to think of, when you're doing a structural heart procedure, and we all know that transfemoral TAVR has the data that supports it as being the preferred method of access and route for TAVR. Knowing how to manage the iliofemoral system has become a routine skill for all structural heart operators. What's very interesting is many structural heart operators didn't necessarily have endovascular training during their fellowship. So learning how to navigate the iliofemoral system has become somewhat of a new challenge. Additionally, until recently, and specifically until intravascular lithotripsy was developed for the peripheral vascular space, we really haven't had a good route of modifying calcium in the iliofemoral system, and that has led to, sometimes disastrous outcomes. You can see here, in Figure A, the most dreaded outcome is a perforation or rupture of the iliac artery, which is almost instantaneously deadly for our patients. And almost, is certain to happen if we are pushing large bore equipment through a highly diseased and calcified iliac artery. And so if we don't adequately treat calcium, that has become a problem, and it's made us search for alternative accesses for TAVR, axillary, carotid, subclavian. But time and time again, data has shown that transfemoral TAVR is the preferred method to use for TAVR. So we need to develop methods to help us navigate this anatomy. So when we talk about the iliofemoral system, and we've all seen these pictures, the snake view when we get our CTA of the lower extremities to plan for access. Oftentimes we see these highly calcified stovepipe arteries, of the iliacs leading into the aorta. Most of our TAVR patients are, elderly, and they're going to have some degree of calcification. And the issue with TAVR, which we still are running into, is that it's a large bore sheath. Most TAVR sheaths are ranging anywhere from 14 to 16 French, which means most of our access sites have to be at least 5.5 millimeters. So in general, that is not a problem in the femoral or common femoral artery. It is a problem and it isn't, but most of the time we actually worry about what the iliacs look like. And is that 14 or 16 French sheath going to be able to safely transverse that iliac artery if it's severely calcified and stenosed? Another issue is when the artery is extremely calcified and tortuous, is that sheath going to adequately be able to transverse that segment safely? And when you're pushing against a rock, it's much harder to get anything up. But if you change the compliance and make the artery more soft and pliable, it's much easier to get that sheath up. And I'll kind of explain that in a second. And then one of the most common, like I said earlier, one of the most common complications of TAVR is access related. So you go in there and you put your valve in and everything goes great, but then on the way out, you have issues with your PER close, you have issues removing your sheath. And like I showed earlier, the most disastrous complication is the perforation of the iliac artery. So what are our options? And this is what I find somewhat, funny, that we don't really have a lot of options prior to IVL in the iliac space. Most operators would just use a high pressure balloon and kind of create space for the sheath. But we realized that, you were solving one problem. You were fixing the stenosis, but you really weren't changing anything with the vessel compliance. And you weren't really, changing how calcified the vessel was. You just made the lumen a little bit bigger. So when you use a high pressure balloon, you can lead to perforations and dissections, because what happens is the balloon inflates and it's going to pick the path of least resistance, which is usually the contralateral side of the vessel that's not calcified, and it's going to push the calcium outward, creating a perforation. It doesn't change anything with deep calcium. You're basically maybe modifying a degree of the superficial calcium, and like I said, it pushes calcium away in an eccentric lesion. And in the iliac system, unlike the common femoral, superficial femoral, and popliteal segments, we don't have atherectomy devices that can be safely used. And atherectomy devices inherently have a lot of risk, and that's why they've never been approved to be used in the iliac system. And this is seen in our guidelines, as you can see here from Sky. When we look at the guidelines for how do you treat aortoiliac lesions, atherectomy is actually considered a class 3 indication, and it's class 3 for harm. So using things like orbital atherectomy, directional atherectomy, they're not indicated in this space. So really our only option was high pressure ballooning. So that's where intravascular lithotripsy has really been what I like to say a game changer. So intravascular lithotripsy is using a balloon catheter that has basically a shockwave emitter, or basically a spark plug that creates a spark that creates a vapor bubble that basically rapidly expands and contracts to create microcavitations, or basically sound waves to break both deep and superficial calcium. It comes from the word lithotripsy, or from the Greek word, it means stone or to break. It's using acoustic energy or sound waves to create microcavitations to break calcium. And what's really unique is that it treats both superficial and deep calcium. And that's the first time we've seen that. So I think this was really explained well. And Ziad Ali has really been a pioneer in this space. And he, with his work has shown, the multiple mechanisms of action of how to treat calcium. And the unique thing about shockwave lithotripsy is that not only does it basically fracture calcium, it does it in multiple different ways. So when you generate that acoustic energy, you basically cause a compressive state on that calcium, or basically you squeeze the calcium and it generates those initial fractures. The second is that propagation of that calcium, or the shockwave through the calcium, that creates both vertical and horizontal fractures in that calcium. And then the shockwave reaches the back wall of the calcium and actually creates a pulling force, which is the spall stress, that further creates jets and fractures of calcium. Then from microcavitations, microjets are created, leading to further fractures of the calcium. And then finally, the impedance difference between the actual soft tissue and the hard calcium creates this squeezing effect that further propagates the fractures that you see in shockwaves. And that's what's been really amazing. And they've shown this in multiple different ways, but I think this is the best way that they've shown it, is using micro CT, or microhistology CT, that shows, this is actually a cut from the superficial femoral artery. And what was amazing when they first showed this was that not only are we getting calcification modification in a horizontal plane, but we're also seeing it in the longitudinal planes, in diagonal planes, and you're also seeing these chips or fractures of the calcium. So not only are you affecting the superficial, you're also affecting the deep. And you can see it here as well. So at the end of the day, it's basically like breaking a plate. And so you break and fracture these calcium, and I like to think of it as like tectonic plates, right? So you originally had this stovepipe, and now you have all these tectonic plates, and these little fractures fill in with fibrous tissue that actually give that vessel compliance and the ability to move. And that's where in large bore access it has become an amazing thing. As you can see here, when we're trying to deliver a large bore sheath or TAVR sheath, it will not push through that stovepipe or unfractured calcium, but we deliver shock waves and break up that calcium and create these tectonic plates, thus allowing that vessel to be more compliant, to allow that valve or that sheath to move up the iliac artery safely. So at the end of this, it basically wanted to tell you that why shockwave has become so amazing. It's not really the effect of the actual stenosis. It's the effect of how we are actually changing vessel compliance. So we're taking a stovepipe artery and we're making it more compliant, an ability to actually accept our sheath and move it up safely through into the aorta, allowing us to safely perform these procedures and avoid our dreaded complication, which is access related.
So Dr. Mohan, that was a very excellent presentation. And I wanted to, however, ask you that although, using IVL is excellent, but how do you circumvent the fact that sometimes you're not able to bill for the procedures, and how do you incorporate that cost in your total TAVR cost?
Yeah, so that's a great question, and I hear it all the time. And that's maybe one of the Achilles heels about intravascular lithotripsy currently, is that the hospital or institution does get some reimbursement, and it has improved now that there's a fragmentation code. But one of the things that you hear in a structural heart program is how do you save costs, because it is an expensive procedure. And if you're adding intravascular lithotripsy on top of that, it kind of increases costs exponentially. So one of the things that I've actually found by talking and discussing with other structural heart operators is that you can actually purchase the small capital cost of the device itself, or the generator that that we have to plug in the catheter. And when you do that, it actually comes with 2 catheters. So you don't necessarily need a catheter-based agreement with the company. You could purchase just the generator, which is a lower capital cost, and it comes with two catheters. And I think now with the new development of the L6 Plus catheter, you could potentially get 2 L6 Plus catheters, which are, larger shockwave balloons, and you can have them for your procedures that you need to use as kind of a bailout strategy to, say you have a transfemoral procedure that needs shockwave, you can use one of those catheters to kind of bail you out. That would not be an off-label use. The L6 and the M5 Plus are completely indicated for the iliac and femoral segments to treat peripheral vascular disease. It's more so, in my opinion, another tool that we can use, because many transfemoral cases we can get away without using plaque modification or intravascular lithotripsy within these segments. But you're going to run into a case where the vessel compliance is an issue, and you may need one of these tools to bail you out, and it's completely indicated for the space.
Thank you, Jim. Thank you very much for that extensive and elaborate discussion on the mechanism of IVL. Now moving on to my topic, which is basically IVL in TAVI, registry data, and where we go from there. Okay, without belaboring, I think you guys got a pretty good teaching on how IVL works and the mechanism of IVL. I would not belabor this anymore, except that, shockwave creates a localized lithotripsy bubble and, basically a fluid-filled balloon with emitters that have, that produces electrical energy and basically produces a bubble that expands and produces sonic pressure, which you learned about pretty extensively. And the fact that it has to be at least 10% oversized rather than undersized so that it makes optimal contact, and there has to be a 1 centimeter overlapping segment. I think we talked about this. I would not belabor this anymore. I do want to touch upon this, that the 2 forms are how coronary IVL differs from peripheral IVL. Basically, the pulses are more. We have 300 pulses in the peripheral IVL versus 8 pulses in the coronary IVL, 80 pulses in the coronary IVL. The size ranges are different, 3.5 to 8 millimeters balloon, and the crossing profile is slightly larger, as you can guess. The lengths are 60 millimeters, and they're compatible with 6 and 7 French sheath. I think it's worth mentioning the most recent iteration, which is the L6 peripheral IVL. They have come up with sizes anywhere from 8 to 12 millimeters. The other good thing is that it's 0.18 wide compatible, which gives a slightly more support, and the balloon lengths are shorter, which is also good when you're trying to address a focal region in the iliacs. So now coming to my topic of data to support the use of intravascular lithotripsy and TAVR. So I just want to introduce this by giving some background about why iliofemoral peripheral vascular disease consistently results in worse outcomes in any large bore access, which also includes TAVR. So the morbidity of an iliac rupture or dissection during a large bore access, as we know, is quite significant. The patients who are at the highest risk are unfortunately the kind of patients we deal with who are going to have TAVR. They usually have more angulation, calcification, very small diminished vessel sizes, and and especially this risk is higher the older you get, the lower BMI, and also unfortunately higher in females. So that said, 1 in 10 procedures will require either adjunctive surgery or facilitated delivery. The use of iliac conduits, which we know from the EVAR data, is associated with pretty significant surgical morbidity and mortality. So non-femoral TAVR, however, has, as I will show in my upcoming slides, has pretty significant mortality as well as morbidity as compared to the femoral TAVR. So 47% in this study, 47% greater 1 year mortality as compared to the transfemoral TAVR. And these poor outcomes are basically worse in the patients because they're frail. This is basically just another way to say the same thing what I have said, that the non-femoral routes, which may be required in about 10 to 15% of the patients undergoing TAVR, are associated with more morbidity, mortality, are more complex, and therefore have more complications as well. I want to go back to the original partner 2A data, which was basically of TAVR versus surgical AVR in the intermediate risk patients. As you can see here, everybody had an STS score of more than 4% to be included in this, and patients were randomized into about 2,000 patients were randomized respectively into femoral and non-femoral TAVRs, those who could not undergo the TAVR through the femoral approach, and they had one-to-one randomized to the surgical arm as well in either groups. And the primary endpoint was all-cause mortality, disabling stroke at 2 years. And as you can see, the point of this was that TAVR is non-inferior to SAVR. However, if we look closely, the interesting thing that arose was that transfemoral in the transfemoral arm, the TAVR actually was superior to the SAVR, and significantly less all-cause mortality and disabling strokes in the patients who actually could undergo TAVR via a transfemoral route. And this was seen enough, the advantage continued up to about 24 months. And similarly, in the patients who were in partner 3 trial, which was of all low-risk patients, less STS score of less than 4%, they were all randomized, about 1,100 patients or so randomized to TAVR versus SAVR. They were actually all transfemoral TAVRs. So, and again, pretty similar endpoints of all-cause mortality, strokes, and cardiovascular rehospitalization at 1 year. And as you can see here, the surgical arm had significantly worse outcomes as compared to the TAVI arm, which were all transfemoral. Therefore, bringing home the point that transfemoral TAVR is definitely superior than surgery. This is again basically the landmark analysis of the same. So again, going back to the point that I'm trying to make is that and there are other studies which basically show the same thing, that as compared to facilitated idiopathic TAVR, alternate access TAVR seems to have worse outcomes. So here's another study that's highlighting the same by Biasco et al., which was presented in cardiovascular medicine in 2018. They basically show the same thing, that the apical and transaortic TAVRs have higher mortality as compared to the transfemoral TAVR, and the transaxillary TAVRs have higher risk of strokes as compared to transfemoral TAVRs. This is worth mentioning. This is the registry data that was recently published in the INSERC intervention, and basically what it highlights is the same outcome of patients who have PAD undergoing TAVR. Essentially, among about 1,700 patients or so that were in this registry, what they found was that the transfemoral and transaortic TAVR were both associated with lower primary outcomes, and at 1 year, the major adverse outcomes were as compared to the transthoracic TAVR. However, at 1 year, the transaxillary TAVR had higher strokes and neurological events. So I don't know how well it translates, but the green is transaxillary TAVR, and the red is transfemoral TAVR, and the blue is other forms of transthoracic TAVR. As you can see, the major adverse events are significantly higher in the transthoracic TAVRs as compared to both the transarterial and transfemoral, and the all-cause mortality was also higher, the thoracic TAVR. However, the strokes and neurological events in this study as well were higher in the transarterial TAVR. And then if you specifically look at the bleeding and especially the major and access site-related bleeding, those were all higher in the transthoracic TAVR arm. Now, this is actually a very interesting paper that basically by Dr. DeMario's group that basically looks at the, it's a prospective registry data of specifically IVL facilitated TAVR, and basically essentially had equal number of males and females in the study. And as you can see that, they had, all of them had pretty significant idiopathic disease and, and pretty significantly calcified vessels, about 260-degree arc of calcium. And 84% of those in the study, they used a 7O balloon. And as we see that the transfemoral delivery as well as performance of IVL was successful in about 100% of the patients. And the great news is that pretty minimal, actually no significant complications at all, no perforations, no full length dissections, and essentially they didn't have to use any provisional stenting either. This is another very interesting paper that highlights the outcomes of TAVR in the patients who have PAD by Bansal et al. Which basically, they showed the adjusted outcomes of TAVR and PAD patients, and patients who underwent peripheral interventions actually with and without PAD and alternative access TAVR in the National Database Registry. So basically, they looked at the National Readmissions Database Registry from 2016 to 17, and they had about 99,000 plus patients, and essentially, it showed that the outcomes in the patients who underwent TAVR and any sort of peripheral intervention, whether it was a peripheral intervention that was because of bailout or it was a peripheral intervention because the patient had PAD, they all did, worse on all these metrics, had more mortality, more strokes, more AKI, needed more transfusions, and very few readmissions. And then again, they showed that patients who had peripheral interventions and needed TAVR in the setting of PAD, they were worse than who just needed peripheral interventions for just bailout. And however, if you look at that, the patients who had PAD and needed peripheral interventions versus the patients who they did, who they saw were undergoing non-femoral TAVR, as you can see here, non-femoral TAVR does worse than the patients who had TAVRs with PAD needing peripheral interventions in almost all areas except stroke. Again, this is another recent study published by Nardi et al. In Neurointerventions in 2012, which basically showed specifically about peripheral IVL for TAVR implantation, and it was a multi-center observational study. There were about 108 IVLs done in TAVI patients. The use of IVL was operator-driven. There was pre-dilatation and stenting, which was also left to the discretion of the operator. There were 6 global sites in the study. This is the patient characteristics of those 108 patients. Slightly higher males, around age 80, and who basically had equal distribution of common iliac and external iliac disease, and slightly higher just common iliac, external iliac disease, and as well as a high preponderance of common iliac disease, an average STS score of 3.3. So basically, as you can see that all of these patients, they did very well in all of their primary outcomes, which was essentially successful delivery of the TAVR catheter and successful implantation of the TAVR valve was pretty high as well, 98%. And most of these patients had the TAVI done at the time of the IVL as well. And overall, a low in-hospital all-cause death, about 3%. No strokes, about 8%, 8% pacemaker placement, and 6.5% AKI, and no periprocedural MIs. So all of the patients achieved successful achieved passage and TAVR insertion. And 32% had balloon expandable valves and 68% had self-expanding valves. The minimal luminal diameter on an average was 4.6. So that's the vessel size. And as you can see, most of the vessels were pretty extensively calcified, greater than 300 degrees arc of calcium. And most of the patients in the study used 7 millimeter balloon. And as you can see, the risk of complications stayed pretty low. 1 perforation, no ruptures, 4 minor dissections, 3 major dissections, and the stent use was also significantly less, about 3% covered and 2%. 2% covered and 3% bare metal stents. And overall, as you can see, the access site-related complications were also not significant, except the BARC 3-8 bleeding, which was slightly higher. And the risk of unplanned endovascular interventions was also slightly higher. Less than 1% vessel rupture, 2.8% full limiting dissections, and about a total of 5% bailout stenting. I would like to go to this very interesting case I did with my partner, Dr. Labib, a couple of months ago. So this was an 80-year-old patient who basically presented for TAVR, had a medical history of prior breast cancer, and also prior cabbage, who had interventions post cabbage, and she had the usual risk factors as well. And this was her T transthoracic echo, which showed a pretty tight valve with a valve area of 0.8 and a mean gradient of 43 and a peak gradient of 69. Her EF was preserved. Okay, so this is her coronary anatomy, which was a patent RCA. She has a patent revascularized LAD and CERC. And here you can see a patent lima on the left of the screen. And in the middle, you can see the J wire during the coronary diagnostic imaging. The J wire, which was there was a difficulty in progressing of the J wire, so on either side, and therefore they went ahead and took an iliac angiogram from up top. I don't know if it translates very well, but there's a bilateral, pretty significant iliac disease. Now this is her TAVR CT. As you can see on the right side, the minimal lumen area at the level of the common iliac exit is very small. It's 3.7, and on the left side it's 4.9. This is the rest of her measurements. So initially, as you can see, we attempted a blind wire, then a platinum plus wire, and eventually a cyan blue was able to cross. And as you can see here, these are the DSC images of bilateral iliacs. This is her left, this is her right, and as you can see, very tortuous and very calcified iliacs. All right, so after we passed the 014 cyan blue wire, we basically made a little room with the 4030 Sterling balloons, and then we did bilateral IVLs, 7 by 60 millimeter on both sides. As you can see here, the coral balloon inflations. You can see the dog boning on both sides, and this essentially wouldn't have accommodated the sheath itself, but it was just to make room for shockwave. And then here you can see the shock waves open up. The shock wave opens the vessel up, and then eventually the left side popped as well. So you can see bilaterally, this is, after we utilized most of the pulses, I think 150 on either sides. And as you can see in this image 3, there seems to be pretty good expansion of the third picture. This was followed by bilateral 8040 Mustang balloons. As you can see in this picture here on the right of the screen, there's very excellent. You can see that there's very excellent bilateral results without any major significant dissections. And this was followed by Sapient 3 Ultra TAVR placement. It was a 23 millimeter valve. Excellent result of the valve. At the end of the case, we basically put bilateral 80 39 millimeter BBX stents and did a kissing bilateral AVX stents. And after which we post-dilated with first with the 80 and then with the 10 millimeter, 10 or 40 millimeter balloons. And here you can see with excellent results. So these are my take-home messages from the case, that IVL helps rendering feasibility of the TAVR to about 95% of the patients. In this case, it was special in the sense that we used this unique technique of using 2 shock waves bilaterally, and therefore optimized our distal aortic bifurcation, and essentially undertaking TAVR through adequately treated iliac arteries in the context of aortic bifurcation disease. It can be performed, and we can do it in the manner we did, which is crack, implant, and then pave the stent. And we had excellent results.
Dr. Kalik, that was some great cases that you presented. I really enjoyed the case where you showed the iliac angioplasty with the history of the aortic repair. One thing that shockwave, I've really realized that you can use it so safely in previous lesions. We'd really be fearful of, dilating, an iliac lesion going into an aortic repair. My question to you is, I've run into some questions regarding previously, whenever we did angioplasty, whether that be in the femoral or the iliac, we always further treated it with something else, whether that be with drug-eluting balloon or stenting. Specifically in the iliac system, we'd always stent it. And then I've run into a lot of other structural operators that are actually telling me, they're getting away with just doing intravascular lithotripsy because it's so safe. It has such a limited amount of dissections that it causes, that they will not stent the iliacs and they'll just do angioplasty with the intravascular lithotripsy. Is that the way that you're handling these iliac lesions, or do you routinely stent them post structural heart intervention?
Well, that's a great question. So typically, if there are no flow limiting dissections, I don't. But if there are any significant flow limiting dissections, or there's a significant recoil, then I do stent them. Yes. Yeah, such as in the case that I demonstrated, we did bilateral casing stents of the iliac. So there was a significant recoil in that case. So we ended up stenting.